Good morning, everyone. This was actually a really interesting talk to put together, and I intentionally didn't make it super long because I think there's really an opportunity to have a really rich conversation about these issues. So I've certainly left time for that at the end, but I was really trying to sort of capture how I have conversations with patients with substance use disorder, the difficult conversations. So the ones that are maybe the hardest to try to start or the hardest to try to finish or really, and it's interesting, I was at the Maine Health Opiate Steering Committee meeting last night, and we had a conversation about kind of harm reduction and how we can sort of help other providers in the healthcare system. And I think one of the things that we've never been taught is sort of how to have hard conversations about these types of issues. So there's a lot of effort into talking about end-of-life care or palliative medicine or kind of when those things shift, but there isn't necessarily training, so to speak, on how to talk to folks about difficult issues that may provoke strong emotions. And then sort of the overreaching kind of how do we do this in a respectful way? And, you know, I don't claim to be perfect at this by any stretch. I just am going to share sort of what has worked for me and how I work with women that really, and I sort of was trying to find the right quote for this, but this one came to me that owning our story can be hard, but not nearly as difficult as spending our lives running from it. And I think that really captures to me when women enter treatment, that's often where they're at. Like, oh my God, I've got to sort of, you know, I was using drugs to sort of get away from all the stuff that I was dealing with, all the stuff that caused me to feel shame. And then all of a sudden there's all this stuff that they're trying to deal with at once, and trying to sort of stay on track can be really, really difficult. Next slide, please. So strategies for having hard conversations. A couple slides on this. So I think first of all, acknowledge your own fears about having hard conversations. Like, this is totally appropriate. And I role play sometimes with the physicians that I train. You know, we'll sit down and I'll say, like, how would you start this conversation? And what would you do? And because sometimes the first question is the hardest. And I think that's one of the things I really like about the 4P screening instrument, sort of as a screening tool, is that it's a lot of open-ended questions. So it can kind of help you have those safety questions to ask in terms of the ones that make you feel safe asking them. But then it takes you down a road with a different conversation. So I think that can be helpful. Really important to set the stage for a therapeutic conversation. We're all super busy all the time, but be mindful of your pager if you still carry one, interruptions, and making sure that you don't appear distracted. So if I know I'm going to have a really hard conversation, I will usually go to the team I'm working with that day and say, hey, really try hard not to knock on the door during this visit, because there's nothing worse than sort of in that moment, you know, you're having this very intimate, painful conversation and there's somebody pounding on the door from the outside. So I try to sort of set that up. Sit down and focus on eye contact. So I think you have to pretend there's nothing else in the world on your mind, which of course never happens when you're in the clinical setting. But, you know, trying to be mindful of everything that's going on. I usually try to just put even my pen and paper aside. Like, I'm here, I'm looking at you, I'm sitting down, I'm at your level, which I think is really important. Starting with open-ended questions can be really helpful. Again, that sort of reference to the screening instrument, just sort of opening up a dialogue and then letting the person take it where they want. You may have a very specific agenda in mind, and usually I have, you know, 3 or 4 points I'm going to try to make, but I let the conversation go in whatever order makes the most sense. And so I kind of let the patient take it from there. I think it's also important, if it's not an urgent issue, to find out how much the patient wants to talk about at a given time. So I think we get to the place sometimes where we're having hard conversations and it's like you can tell the patient has just they're up to here. You know, they can't, that first visit with patients, I always feel like when I finally get to the point about the extended hospital stay, you know, substance exposed infant notification, they've almost maxed out on their capacity to take it all in. So it's okay to say, hey, is this, you know, do you want to talk about this another time? You know, provided it's an okay thing to do that. You know, certainly with a DHS concern about safety, you might not be able to do that. I always try to ask the patient questions to make sure that she's understanding what we're talking about. So just, you know, a lot of sort of reflective questioning, like, I hear you saying this. Am I understanding that, you know, that's your takeaway on this? So just a lot of sort of repeating, I think, clarifying questions. And then always never hesitate to be like, hey, was that answer helpful? Like, did I actually answer the question you were asking? Because sometimes, I mean, I'm really good at this. I hear a slightly different question and then I answer that question and that's not the one that mom had. So it'd never be shy about asking that. And I think it also helps to show, like, I certainly feel like sometimes showing my own vulnerability like helps them feel a little bit more vulnerable. Like, hey, this is a hard conversation. I sometimes leave and say that to the patient. This is a really tough conversation to have. And, you know, and just sort of like opening it up, like this is tough and it's going to be tough for both of us. So let's try to do it in the best way for both of us. Many of the common concerns I would say with women with OUD are around the DHS referral, the extended infant hospital stay, pain management, and shame and stigma. And I'm not going to get into the super specifics of most of these, but just kind of some of the general techniques that I use. Next slide, please. So this is how I think about discussing this substance-exposed infant referral and concerns about child welfare. And I'm kind of going to come at this from two different angles. One is sort of the conversation about, so say it's a first pregnancy, there's a substance-exposed infant notification, so you've got kind of 9 months to address that. Sometimes what happens is a patient comes to you, they're in the throes of a substance use disorder. They've got an 18-month-old at home, and you know they're actively using heroin and cocaine. And you're trying to think. So you got kind of two things going on. You got the substance-exposed infant notification issue, but you've also got safety concerns potentially about what's happening in the home. So sometimes this part is going to sort of bridge into both areas. I will say if you have concerns about welfare of the children in the home, talk about it sooner rather than later. Putting it off, I think, generally makes it harder and more difficult to address. So in that very first visit, if I have a person who's actively using a lot of different substances and they have a small human in the home, I'm generally being forthcoming about, hey, I'm pretty concerned about this. If I feel that I have to report that day, I tell them very clearly. I don't do that very often with the primary goal of getting her to come back. That's like at my first visit, that's usually my primary goal is getting her to come back. But I'm really honest about, geez, I'm potentially concerned about your small child in the home when you're using drugs, and sort of talk those things through. Be prepared for your discussion, as I already mentioned. Have a clear agenda of what you want to talk about. So if you've got 3 points, make sure you get to them. But again, I usually let the patient take it in their own way. Sometimes I actually summarize the statute, the substance exposed infant notification statute, because it can be confusing for folks, and people think, well, geez, I'm in treatment. Why do I have to be referred? And if I, explain it, it's born exposed to any substance that could cause a withdrawal syndrome, then you can just sort of explain, this is how the statute's written. Like, there's nothing I can do about that. So this is why you're sort of falling into that category. I think it's really important to be open and honest with patients. I just subscribe to that as a general rule. I am always, if a patient says, did you report me to DHS? Yes or no, whatever it was. And I'm always, if I will tell them if I know I'm going to do it. But the sort of caveat to that is sometimes I end up reporting sort of after a drug screen that's kind of unexpected. And if I didn't have that conversation with them in the room, I can't necessarily do it at that point. But I'm always really honest with patients. I'm specific about what my concerns are and what I've observed. And so the other thing I think that sometimes comes up is that patients will say, do you think I'm a bad mother? Why are you doing this? And I think, I think what I really try to do is say, hey, I am not the ultimate sort of arbiter of a safe situation at home. I am a person who sees you 30 minutes out of the week, and I have these concerns, but I don't know what's going on the other, every other hour of your week. And so I feel like somebody who's an expert in that, and I say Child Protective Services is an expert in that, is the one who's the right person to make the decision about whether or not things are safe at home. And so I just try to sort of state that. I try not to make assumptions about what patients need to know. Like, I try not to be at all sort of paternalistic in that way. I try to be forthcoming with whatever my thoughts might be. Next slide, please. Listen to patients carefully about the questions that they ask, and certainly acknowledge that this can be an anxiety-provoking conversation, totally appropriate. I think it's really good to understand previous DHS experiences. That certainly often will flavor sort of the conversation, and it may not be their own DHS experience. So it might be just, my sister had this experience and I watched her go through it. So just because this could be like a first pregnancy doesn't necessarily mean that they have a sort of benign view about Child Protective Services. So I think it's important to sort of try to elicit, what other experiences have you had? It was mentioned in the previous lecture, but please don't make any promises about what DHS is going to do in terms of decisions about supervision or custody. I will sometimes say, geez, I've been doing this 15 years and these are some of the things I've seen, but I am always careful to say, every situation is different. And again, there's lots of other people involved in your life. And so, many times this is not a substance use disorder question, right? So sometimes like we have this very myopic view about substance use disorder treatment, but maybe the situation that's making the place unsafe is the intimate partner violence, which might not be right in our face, but somebody else might be reporting. So just be aware that I've learned that the hard way, right? You don't have the full picture. And so, certainly don't make promises that you really can't keep effectively. If I know things are not going well, I sometimes will brainstorm with patients about resources and support. So like I have actually broached the subject with patients that, geez, I'm really concerned that you're maybe not going to be able to go home with this baby unsupervised. You have other people in your life that could potentially play that role, to really help them think about sort of building, strengthening relationships that might be present. This is a dicey one, doesn't always go great. But I would say about 75–80% of the time it does go great. So that one you may not want to deploy immediately, but it is something that has been helpful for patients to think about. Like, it's almost makes them feel more confident. Okay, well, geez, I hope I can go home unsupervised, but if I don't, I've got this really great aunt who could serve as a supervisor. So that almost makes them feel a little safer about the situation. Showing empathy is super important. Make a genuine effort to understand the patient's perspective, even if you disagree with it, right? I mean, just, try to just sort of understand and meet them where they're at, offer support without judgment as much as you can. Next slide, please. I think it's really important to be prepared for a variety of different responses. So some people feel relieved when this issue comes up and grateful for the chance to talk about their situation. So again, sometimes I have uniformly heard over the years that patients really appreciate that I'm super straightforward and honest about the DHS side of things. Like, they don't like it when they're sort of wondering, like, is something happening behind the scenes? Is she telling them something that she's not telling me? Like, understandably, that's not a popular thing. So sometimes patients are actually relieved when it's like, hey, this is the situation, this is how it works. They feel, okay, we can talk about this openly. Other patients become, angry, they're insulted. I mean, oftentimes, why do you think I'm not a good mom? That sort of comes up. Or they're fearful. I mean, I've had some really compelling conversations with patients who they themselves were foster children or involved in the foster care system, and they had negative experiences. So that's this fear that sits in their brain constantly, that like, oh my goodness, what happens if this child gets removed and they had the same experience I do? So there's oftentimes a lot of things that are going into their response. Anger is a normal human emotion, response to perceived threat or loss of control. So again, if you feel unsafe, you should get out of the room. Like if the anger gets that bad, but it's not uncommon for people to yell a little bit or be frustrated or cry. And again, I'm not suggesting you should be putting up with being abused as a provider, but sometimes just stepping out of the room, if there's a really hard response, you can just say, hey, I'm gonna give you a minute. I'm gonna step out. Sometimes if you're concerned, you can certainly bring someone back in with you, but sometimes just that sort of giving them a time to cool off does make a difference. So again, talking about, oftentimes it's the fear that you're sharing things without their consent or past experiences with authorities. So just, again, trying to be open about that. Talking about this process is an opportunity for you to show that you care and that you're really trying to help advocate for that patient and the child. And I really talk about that openly when I have a situation where the mom's doing really well, but she's really fearful. Like, hey, I'm going to be your advocate. When this DHS report is filed, like, I'm going to say that you made your appointments, that your urine drug screens were totally appropriate, that you're doing the counseling that we've encouraged you to do. And so that can help them feel like, hey, I've got this team on my side. And if there's a crisis, acknowledge that it can be really stressful. So sometimes, you'll come in and like the child got removed from the home between your last visit and whoa, the visit did not go in the direction you think it's going to go. And you just sort of roll with that as it happens. Next slide, please. So I think strategies for talking about extended infant hospital stay and pain management, again, we're not covering that in detail, but I just explain why the extended infant hospital stay is necessary and how it might feel for the patient. So I try to describe we're monitoring for this withdrawal syndrome. It's very safe if we're monitoring for it, but sometimes I do, let's talk about how you might feel if your baby experiences some withdrawal symptoms. Like, what will that, because women tend to be so blaming of themselves and so negative about themselves because, oh my God, how did I put my baby in this situation? So sort of starting to talk about those emotions and making sure that they feel that they can talk about those emotions when they're on the inpatient unit. We talk about Eat, Sleep, Console, how it differs from Finnegan's, and if they've had previous experience with, withdrawal syndrome, kind of what that looks like, how it's different now. What I really try to talk about with Eat, Sleep, Console is it's much more empowering for the parent. Like, you are part of that treatment team. You're helping to make decisions. Is the baby eating okay, sleeping okay? All those questions. You're part of that group that's making the decision, as opposed to somebody coming in and kind of scoring your infant and you're sitting on the outside of it. I really try to empower patients to speak up and ask questions. That's a hard thing, because generally, the experiences they've had in life has not encouraged them to speak up for themselves and their own needs. But I really try to empower patients. I do remind them that, hey, that your infant's going to be in for at least 5 days. That might be longer than the quote unquote typical. In other words, the infant that's not being monitored for withdrawal. So talk about your patient about how you want to handle that. Like, okay, so if one of the nice things about COVID is that we don't have thousands of people in the hospital. But if they have a family member who comes in who's like, why is your baby still here? It's day 4. Just think about, I always like my parents to feel prepared, so that they just know that might be a question, and that whatever they want to say, geez, the baby's having trouble eating, or, that they're having trouble latching, or whatever the issue is, so that they're just prepared to answer that question. I try to talk about how opioid analgesics work, reassure around feelings of feeling high or experiencing withdrawal. Those still come up. And we talk about potential triggers. Are you worried about pain management and those issues? Next slide, please. Thank you so much. So I was reading about this and just thinking about how to work with women who experience shame and stigma. And I like this sort of paragraph because I feel like it really captured that. So shame can occur when early attachment repairs, like apologies and explanations, did not heal the pain of the shame that was first occurring. So we think about attachment issues. So often large or small misattunements between parent and child where the emotional needs are not noticed or met can lead to shame. It can remain hidden, toxic, and unhealed. And when there's actual abuse, children receive the message deeply that they do not matter and are worthless. And then they can lead this life in sort of pervasive shame and constricting their life and keeping them in a blanket of depression and reactivity. I thought this sort of beautifully captured our patients in many ways, that they've experienced so much in their life. They're just feeling like their value and their worth is just so minimal. So I really try to work with patients to practice sort of, forgiveness is probably not quite the right word, but self-compassion. If there's a lot of negative talk about themselves, try to think about, like, geez, would you say that to your friend who experienced this? And trying to reframe that toxic self-talk and false beliefs. This can be, I think, some of the hardest work that we do. And there's other people on this call who are, I'm sure, far better at this than I am. But just constantly working on that piece. And I think particularly with COVID, beyond shame, many patients are feeling hopeless and isolated. And I just try to be present, listen, validate, and support. So, just be that source of a safe place where they can come and talk about their emotions. And I think the one thing to remember is that you may very well be the first person in their life who cheered their successes and believed that they had any value and were worth helping. And I can't tell you the number of times I've heard patients say that, you're the first person who believed in me, or you're the first person who really cared about me, or you're the first person who didn't treat me like a piece of shit, for lack of a better way of putting it. So don't underestimate your importance in this relationship, even if you feel like sometimes you're not very good at having the conversations. That just being there and showing that you care is more than many, many, many other people in their lives have ever done for them. So that's my thoughts for the day.
Thank you so much, Elaine. I think it's true that this was a really powerful quote that you added, and even what you just said at the end too, about the context of this presentation is to really set the stage on how to talk about difficult things, and just showing that you are there as a compassionate support for people is probably one of the biggest things that you can do. So thank you for saying that. We know that you take a lot of